Welcome to the Hospital Medicine Unplugged podcast. Today we're doing an evidence-based deep dive into superior vena cava syndrome, SVCS. We'll be focusing on the critical diagnostic steps, the management algorithms really necessary for our hospitalized patients, especially important now as the etiology of this syndrome, well, it continues to evolve in modern practice.
It really does. This is a high acuity condition, and its prevalence is undeniably rising. It just demands that every hospitalist be proficient, not just in recognizing the signs, but really understanding the precise physiologic ramifications and, importantly, the urgency required.
Let's start right there with the basics, the definition.
Okay, so SVCS is essentially the constellation of signs and symptoms that result from the obstruction of blood flow through the superior vena cava, the SVC.
And the physiology behind that definition is, well, it's crucial for understanding why symptoms manifest the way they do. The SVC is a major vessel, right? High volume.
Absolutely. It's responsible for draining all the venous blood from the head, the neck, the upper extremities, and the upper thorax.
Physiologically, this massive vessel handles roughly, a third of systemic venous return?
Yeah.
Straight into the right atrium.
That's right, about a third. So when obstruction occurs, you get an immediate and pretty severe elevation of venous pressure proximal to that stenosis.
And that elevated pressure explains everything you see clinically, essentially.
It really does. But what determines the severity, it's not just the degree of obstruction. Critically, it's the rapidity of the narrowing, how fast it happens.
Right. So if the onset is acute, really rapid.
The patient experiences far more severe, often life-threatening symptoms. And that's because the body just hasn't had adequate time to form functional collateral venous pathways.
We should probably elaborate a bit on those collaterals. They're important.
Definitely. So when the obstruction is chronic, or maybe it develops slowly over weeks or months, the body actually has time to divert blood flow via alternate routes.
Like the azygos system?
Exactly. The most important of these is the azygos vein system. This system acts as a major bypass route, shunting blood around the obstruction and eventually dumping it back into the inferior vena cava.
So it mitigates the symptoms, at least somewhat?
It does. It lessens the severity. But if the obstruction is instantaneous, say from an acute thrombus, that bypass system just isn't ready. It's not developed enough, and you get this devastating pressure buildup.
That distinction, acute versus chronic presentation, that sounds like a really critical triage point for us in the hospital.
It absolutely is. And clinically, SVCS is far more than just, some swelling. It can be a catastrophic syndrome.
We're talking about potential airway obstruction.
Right. From laryngeal edema, cerebral edema leading to altered mental status.
Which can be subtle at first.
Very subtle. And in severe cases, even hemodynamic instability. It has a profound impact on central venous return.
And the etiology, as you mentioned right at the start, it's changing. That's a key point for practice today.
It is. Historically, maybe infectious causes, things like tertiary syphilis or TB, leading to fibrosing mediastinal. Those were more common.
But now, in contemporary hospital medicine,
we're focusing on two primary, rapidly increasing drivers.
Okay, what are they?
First, the rising prevalence of malignancy, particularly thoracic cancers. That accounts for the vast majority of cases, often 80 to 90%.
80 to 90%, wow.
Yeah. And the second driver is the widespread reliance on indwelling central venous devices, things like CVCs, pacemakers.
Which introduces a whole new category of sort of benign thrombosis and stenosis.
Precisely.
Okay, let's delve into those malignant causes first, since they're the majority. What are the big players?
Non-small cell lung cancer remains the dominant culprit. It's responsible for approximately half of all malignant SVCS cases.
Half, okay.
Following that, we see small cell lung cancer quite frequently, then various lymphomas and metastatic tumors too.
Metastatic, like?
Often breast or testicular cancer metastasizing, or sometimes mediastinal germ cell tumors.
Got it. And how does the malignancy actually cause the obstruction? What's the mechanism?
Well, the mechanism of obstruction in malignancy is typically threefold. And it's important to try and distinguish these on imaging, if possible.
Okay.
First, you can have external compression by just a large tumor mass. You often see this in lymphoma, or maybe a massive non-small cell lung cancer.
Squashing the vessel from the outside.
Exactly. Second, you can have direct vessel wall invasion, where the tumor actually grows into the cava wall, compromising its structural integrity. Or third, and this is a bit less common, you can actually have an intraluminal tumor thrombus growing inside the vessel itself.
Okay, 3 distinct mechanisms. Now, on the flip side, Let's talk about those increasingly important benign causes.
Right. This subset is almost entirely device-driven these days. We're seeing much more SVCS related to thrombosis or stenosis induced by indwelling hardware.
So central venous catheters, pacemaker leads, ICDs.
Exactly. This typically involves chronic inflammation or maybe damage to the vessel wall from the device itself. That leads to slow, progressive stenosis, and then often subsequent thrombus formation right around the device.
So it's more of a chronic process, usually?
Often, yes, but it can present acutely if a thrombus suddenly forms or propagates.
And while these device-related cases are the main benign cause, are there others we should keep in mind?
Yes, definitely. While device-related cases are primary, we can't forget less common non-malignant etiologies.
Such as?
Well, conditions causing chronic inflammation or fibrosis. Things like fibrosing mediastinal, which is often idiopathic or sometimes post-infectious, maybe histoplasmosis in some areas,
Right.
and also patients with underlying hypercoagulable states. Think about things like antiphospholipid syndrome.
Okay, so recognizing the etiology is paramount, clearly, because benign causes, while they still need urgent treatment for symptoms, they carry a vastly different long-term prognosis than malignancy.
Hugely different, absolutely critical distinction.
That sets the stage perfectly for clinical recognition, then. This is where the hospitalist really needs to be sharp. Rapid, accurate recognition. That's the first step towards effective triage, and then making that critical decision on how urgent the intervention needs to be.
Exactly. The syndrome results from impaired venous drainage of the upper body, as we said. And that gives us a pretty classic, usually highly recognizable presentation.
So what are the most common things we'll see if we're looking at high-frequency data from major studies?
Yeah, the presentation is quite standardized, actually. Facial and neck swelling, that's present in up to 82% of cases. It's very common.
82%, okay.
Upper extremity swelling follows closely behind, maybe around 68%.
Yeah.
And respiratory symptoms are also highly prevalent.
Like shortness of breath.
Right. Dyspnea is reported in about 2/3 of patients, and cough in maybe half.
And what about those visual cues, the things you can just see walking into the room?
Well, one of the most pathognomonic visual cues and a finding that immediately suggests chronic high-pressure obstruction is the presence of dilated chest vein collaterals.
You see them on the chest wall, neck, upper arms.
Exactly. They're present in roughly 38% of patients. When you see those sort of serpentine and gorged vessels snaking across the chest, that's pretty much diagnostic for an SVC flow issue.
Okay, highly suggestive.
Very highly suggestive. But we need to move beyond just listing symptoms. We need to focus on functional compromise. That's what dictates the urgency of treatment.
What do you mean by functional compromise?
Well, when the edema extends to critical structures like the larynx or pharynx, that's when patients can develop hoarseness, dysphagia, or most terrifyingly, stridor.
Stridor is the big one.
Absolutely. Any patient exhibiting stridor must immediately be categorized at the highest level of urgency. That signals critical, imminent airway compromise. It requires intervention within minutes, literally not hours.
Okay, so let's focus then on the evidence-based physical examination. Beyond the generalized edema and the JVD, which everyone knows, what are the specific visual cues that tell us about severity or maybe even the underlying etiology?
Right. Look closely at the head and face. You'll often see a distinct cyanosis and plethora that's a sort of reddish-blue discoloration of the face and upper body caused by severe venous congestion.
Okay.
Periorbital edema and conjunctival injection, those bright red puffy eyes, are also really strong signs of proximal venous hypertension.
And in terms of associated physical findings, are there specific things we should actively look for?
Yes, definitely two things. First, assess for a pleural effusion. Data shows this is present in up to 2/3 of patients with malignant SVCS.
2/3, that's high.
It is. And finding that effusion is actually a massive diagnostic opportunity, which we'll come back to.
Okay. And the second thing?
Second, remember that patients with thrombotic SVCS, those often benign device-related cases, they frequently report upper extremity pain or discomfort. That's related to the acute venous occlusion itself.
Makes sense. So the initial assessment has to be systematic, aimed at identifying life threats before we even think about definitive diagnosis.
Absolutely. A rapid check for stridor is mandatory. Airway assessment first.
Then?
Next, a neurologic exam. Assess for altered mental status, confusion, severe headache. These are immediate red flags for cerebral edema.
All right.
And finally, the physical exam absolutely must include a search for palpable lymphadenopathy. Particularly check the supraclavicular or peripheral nodes.
Why is that so critical?
Because if they're present, they provide a potential low-risk, easily accessible site for tissue diagnosis. You might be able to get the answer with a simple node biopsy and avoid a much more invasive procedure like a mediastinoscopy.
Okay, that's a key practical point. Now, to bring some structure to assessing urgency, we often rely on classification systems. The Yale clinical grading system comes up a lot.
Yes, it's a validated tool designed specifically for SVCS. Its purpose is to classify severity based purely on symptoms, which then directly guides the urgency of intervention. Every hospitalist really needs to internalize this system.
Can you walk us through the grades?
Sure. The Yale system nicely stratifies the risk. Grade 1 is mild. This involves only mild facial or neck swelling. Crucially, there's no functional impairment and no respiratory or neurologic symptoms.
So these are the patients where we have some time.
Exactly. These are the patients where we can afford a deliberate diagnostic workup, adhering strictly to that biopsy imperative we just discussed.
Okay. Grade 2.
Grade 2 is moderate. These patients present with more moderate swelling face, neck, upper extremities, and maybe some mild dyspnea or cough.
So worse swelling, maybe some breathing symptoms.
Right. The distinction from grade 1 is the increased severity of the swelling, but the critical point, and this is what keeps them out of the immediate danger zone, is that there is no airway compromise and no cerebral symptoms.
Still time for a planned investigation and definitive therapy.
Correct. Again, allows for planned workup.
And then grade 3.
Now, grade 3 is severe. This is the category that demands immediate, urgent intervention, often within hours.
What defines grade 3?
This is triggered by any life-threatening symptom. So, frank airway compromise, like stridor. New or worsening cerebral symptoms, confusion, severe headache, coma due to cerebral edema, or evidence of hemodynamic instability or shock, like refractory tachycardia or hypotension.
That grade 3 designation really sounds like the pivot point in the entire management algorithm.
It absolutely is. Identifying a grade 3 patient means you essentially bypass the non-emergent workup for the moment and shift instantly toward rapid decompression.
Which is almost always.
Almost always endovascular stenting these days. You move from diagnose first to stabilize first.
Okay, so once we have the clinical suspicion and we've applied that severity grading, we move immediately to diagnostic evaluation. Imaging is essential here. Confirm the obstruction, delineate its extent, maybe suggest the cause. What's the standard first-line test?
Contrast-enhanced chest CT. It's the workhorse. It is unequivocally the preferred first-line imaging modality.
Why CT? What does it give us?
It gives us an unparalleled 3D view of the chest, really, and it provides several critical pieces of information all at once.
It sounds truly multifunctional.
It is. It delineates the exact site and the extent of the SVC obstruction that's essential for planning any surgical or interventional approach. It lets us evaluate the collateral circulation so we can visually confirm if that azygos bypass system is active and how well it's working.
And critically?
Critically, it helps differentiate the precise mechanism of obstruction. Is it extrinsic compression by a mass? Is it direct vessel invasion? Or is it purely intraluminal thrombosis?
And that differentiation often dictates the next step, right? Whether we focus on shrinking a tumor or just opening the vessel.
Exactly. Plus, beyond the SVC itself, the CT provides essential oncologic data. It helps stage the underlying malignancy, if present. It locates primary and metastatic sites, which is vital for the eventual definitive oncologic plan.
So it gives the procedural roadmap, too.
It literally provides the roadmap, allowing interventional radiology or thoracic surgery to plan the best access site and approach for stenting or other interventions.
Are there alternatives if you can't get a contrast CT?
Sure. MRI is generally reserved for the minority of patients with contraindications to iodinated contrast. Venography, direct injection of contrast into the vessel, is typically reserved now for immediate procedural planning, maybe just prior to placing a stent. It does offer the highest resolution of the internal vessel structure itself.
Right before the intervention.
Exactly. And for that critically unstable grade 3 patient we talked about.
The one needing immediate stabilization.
Right. For them, we might rely initially on bedside assessment like POCUS and transthoracic echo. These can give rapid, though limited assessment of flow dynamics and cardiac output, helping confirm the impact of the obstruction. But they're significantly less sensitive for defining the full anatomic extent of the cave obstruction itself. You still need the CT when time permits and the patient is stable enough.
Okay. This brings us right to the heart of the clinical tension, the need for tissue diagnosis. The American College of Chest Physicians, the ACCP, has clear recommendations here, right?
Very clear. They recommend histologic or cytologic confirmation before initiating definitive therapy, unless emergent intervention for that grade 3 presentation is absolutely mandatory.
That's the primary directive. Why is it so important?
It's there for a very good reason. Treating a malignancy without a tissue diagnosis runs the risk of giving the wrong treatment entirely.
For example?
Well, for example, chemotherapy is the primary treatment for small cell lung cancer, but radiation or stenting is often preferred initially for non-small cell lung cancer. If you give an empiric course of radiation, for instance, to what turns out to be lymphoma, you might delay the appropriate systemic treatment for a highly chemosensitive tumor.
Okay, so the principle is clear. Diagnose before treating unless it's grade 3. But how do we actually get the biopsy safely in a potentially unstable patient with venous congestion?
That's the challenge. The strategy must prioritize peripheral biopsy sites first. We actively hunt for palpable lymph nodes, supraclavicular, axillary, cervical. A simple excisional or core biopsy from these sites minimizes procedural risk and avoids invading the congested thoracic cavity.
And if those peripheral sites are negative or just not there?
Then we're forced to consider more invasive methods. Things like bronchoscopy with transbronchial needle aspiration, maybe CT-guided transthoracic needle aspiration, or even mediastinoscopy.
And the yields?
The yields vary significantly with these methods, and the risk definitely increases, especially the risk of bleeding in a congested field.
Okay. And circling back to that physical exam finding we noted earlier, the pleural effusion, you said that was a diagnostic opportunity.
Huge opportunity. Since it's present in up to 2/3 of malignant SVCS cases, getting cytologic analysis of that pleural fluid obtained via a relatively low-risk thoracentesis can often provide the definitive diagnosis needed.
So it could bypass the need for those more invasive biopsies.
Exactly. That's a clinical win when it works out.
Now, what about for the increasingly common benign device-related SVCS? Does the diagnostic workup differ?
Yes, it shifts entirely. We must specifically evaluate for catheter-associated thrombosis or stenosis using imaging like CT or venography. Once that's confirmed, the management often centers on removing the device, if possible, and starting systemic anticoagulation.
Is anticoagulation enough usually?
Often not entirely, especially for symptom resolution. Relying solely on anticoagulation is frequently inadequate, given the degree of underlying physical stenosis that often develops around the device. Endovascular treatment is usually needed too.
Okay, that makes sense. Now let's transition from diagnosis to management. We're returning to those two overarching goals. Stabilize the patient and treat the underlying cause. Let's start with immediate supportive care.
Right. The supportive measures are simple, but they can be effective in reducing immediate patient distress. Head elevation is crucial.
Just elevating the head of the bed.
Yep. It uses gravity to reduce hydrostatic pressure, which directly helps mitigate the facial and cerebral edema. Supplemental oxygen is standard, especially given the high rate of dyspnea and that potential for airway compromise.
What about medications? Glucocorticoids come up a lot. Dexamethasone?
They do. Glucocorticoids are a management choice that needs careful nuance. We often use dexamethasone, typically 4 milligrams every 6 hours. But this is primarily beneficial only when the underlying suspected diagnosis is a tumor known to be steroid responsive.
Like lymphoma?
Exactly, namely lymphoma, mediastinal germ cell tumors, or thymoma. For those, steroids can shrink the tumor and relieve pressure quickly.
But what about other causes, like the more common non-small cell lung cancer?
Well, the evidence for generalized use across all SVCS etiologies, especially solid tumors like NSCLC, is quite limited. They're not a guaranteed symptom reliever. And more importantly, as we've emphasized, if you give them before the biopsy.
They can interfere with the diagnosis.
Correct. They can potentially lunalyze the tumor cells or shrink the lymph nodes, destroying our chance for a definitive tissue diagnosis. So this reinforces the ACCP guideline. Ideally, hold the steroids until after the biopsy, unless the patient is grade 3 and the suspected diagnosis is clearly one of those steroid-responsive tumors.
Okay. What about diuretics? Sometimes used.
Sometimes, but their benefit is really uncertain. The core issue here is mechanical obstruction, not primary volume overload. So diuretics usually don't help much.
So the real trigger for aggressive urgent action remains that grade 3 diagnosis.
Absolutely. Airway compromise, cerebral edema, or hemodynamic instability necessitate immediate intervention. And that intervention, overwhelmingly, is endovascular stenting for rapid mechanical decompression.
Okay. Now, turning to definitive therapy. This has to be meticulously tailored to the etiology that we hopefully confirm by biopsy. Let's start with malignant SVCS. How does treatment hinge on the tumor type?
It's entirely guided by tumor type. For small cell lung cancer, the primary treatment is systemic chemotherapy.
Why chemo first for small cell?
Because small cell is typically highly chemosensitive. The tumor burden often shrinks rapidly, quite dramatically sometimes, following the initiation of chemo. This frequently provides symptom relief within just days. So if we confirm small cell, we push for chemo first, if possible.
Okay. Conversely, what about non-small cell lung cancer or other solid tumors?
For those, systemic chemotherapy is often less immediately effective at achieving rapid tumor, debulking sufficient to relieve the obstruction quickly. So the initial interventions usually involve radiation therapy and/or endovascular stenting.
And you mentioned a shift towards stenting.
Yes, we've definitely seen a paradigm shift over the last decade or so, strongly favoring stenting, especially for initial palliation.
Why the shift?
Because the mechanical intervention of endovascular stenting provides immediate relief. Radiation therapy works by shrinking the tumor, right? But that takes days to weeks to translate into clinical improvement. Stenting, however, mechanically forces open the obstructed vessel. You usually see symptom improvement typically within 48 to 72 hours.
That speed is critical, especially for someone bordering on grade 3.
Absolutely critical, especially for a grade 2 patient who looks like they might be deteriorating towards grade 3.
So stenting is good for primary therapy.
Yes, particularly in acute settings where rapid relief is non-negotiable.
Yeah.
And it's also highly successful as salvage therapy for cases that are refractory to chemo or radiation. The data supporting its immediate hemodynamic impact are really overwhelming.
Okay. Now, what about the approach to benign SVCS? Completely different focus, right?
Completely different. The focus is on repairing the damage to the vessel itself. For device-related thrombosis or stenosis, endovascular therapy, meaning angioplasty, often followed by stenting, is first line.
And the success rates there?
The technical success rates in these benign cases are impressively high, often reported around 97%. And clinical success rates, meaning symptom improvement, are near 93%. Very effective.
What if it's purely an acute clot, maybe recent symptoms?
For acute thrombotic SVCS, if the symptoms are very recent and imaging suggests the obstruction is primarily clot without much underlying chronic stenosis, then catheter-directed thrombolysis can be considered.
That's delivering TPA or something similar right to the clot.
Exactly. Delivering a clot-busting agent directly to the thrombus site via catheter. This is most effective when there's minimal chronic organized fibrosis or underlying fixed stenosis.
And lastly, what about surgery? Is there a role?
Surgery is really reserved only for refractory cases. Surgical repair typically involves bypass grafting, connecting a patent vein below the obstruction, like the subclavian or innominate vein, directly to the right atrium using a graft.
When would you need that?
This is typically used when the vessel is completely encased by dense mediastinal fibrosis, maybe from old infection or radiation, and it's just completely unamenable to any endovascular techniques. It's a last resort.
Okay. Moving now into outcomes and complications. The data supporting endovascular therapy sounds robust, but you mentioned a cautionary note.
Yes. We noted the pooled technical success rates for stent placement are great, around 97%, and clinical success rates 93%. Patency rates, the stent staying open, exceed 90% at 1 year. That all sounds incredibly successful on the surface.
It does, but...
It is good, but the devil is in the details regarding longevity and durability. While the immediate complication rates from the procedure itself are generally low, typically 5 to 10%.
Okay.
We absolutely must highlight the substantial need for reintervention down the road. Reintervention is required in up to 27% of cases. That's almost 1 in 3 patients needing another procedure on that stent.
1 in 3? Why? What causes the failure?
The need for reintervention points to the primary mechanisms of failure. First, stent restenosis, where the vessel wall essentially grows back into the stent over time, marrowing it again.
Like scar tissue.
Sort of, yes. Yeah. Intimal hyperplasia. And second, stent thrombosis, where a clot forms inside the stent device itself.
And this high recurrence rate, nearly 30%, that's why the discussion around anticoagulation after stenting becomes so clinically difficult and important.
Exactly. It's the crux of the long-term management challenge.
What about the risks of the stenting procedure itself?
Well, infrequent, they can be serious when they happen. Risks include things like stent migration, the stent moving from its intended position, in-stent thrombosis, as we mentioned, bleeding, particularly at the access site, and rarely, major complications like pulmonary embolism from a dislodged thrombus, perforation leading to cardiac tamponade, or severe infection.
So meticulous post-procedural surveillance is mandatory.
Absolutely mandatory.
Now, shifting back to disease-related complications, we have to remember those acute, life-threatening risks we started with.
Right. Always keep them in mind. Stridor leading to airway compromise, cerebral edema causing severe neurologic symptoms, and hemodynamic instability or shock from decreased venous return. Those are the acute hurdles we need to clear first.
But stepping back, what determines the patient's overall long-term prognosis? Is it the SVCS itself?
Generally, no. The overall long-term prognosis is determined almost entirely by the underlying disease process, not by the SVCS itself. SVCS is rarely the direct cause of death. It's usually the malignancy driving the obstruction that ultimately determines survival.
So for malignant SVCS, what does survival look like?
Well, the reported median survival is approximately 6 months. But you have to be really careful with that number. It's a massively misleading average.
Why misleading?
Because the prognosis is far, far better for patients with highly chemosensitive tumors. Think lymphoma, mediastinal germ cell tumors, or small cell lung cancer compared to those with advanced refractory non-small cell lung cancer, which obviously carries a much poorer outlook. It varies hugely by cancer type and stage.
Okay. Are there data on in-hospital mortality specifically?
Yes, some data suggests in-hospital mortality is significantly higher for solid tumors compared to hematologic malignancies, maybe ranging from 17% to 26%. And specifically, acute SVC thrombosis in the setting of lung cancer is associated with increased mortality and longer lengths of stay.
And for benign SVCS, the outlook?
For benign SVCS, the long-term prognosis is generally favorable in terms of survival. However, as we emphasized, that high recurrence rate means ongoing surveillance and the potential need for reintervention are necessary parts of long-term care.
Which brings us to monitoring and follow-up. After an intervention, say stenting, what's the plan?
Post-intervention, close observation is non-negotiable. We must meticulously monitor for the resolution of those critical respiratory and neurologic symptoms, usually within the first 24 to 72 hours. This is the period where we confirm the clinical success of the intervention. Did it work?
And beyond the immediate post-procedure period, imaging follow-up.
Yes, imaging follow-up is necessary to assess the patency of the stent and look for early signs of stenosis or thrombus. This is typically done with serial contrast-enhanced CT or sometimes venography.
How often?
Practice varies, but a reasonable schedule might be initially at a 1 to 3 months post-procedure, and then perhaps at 6 to 12-month intervals after that, or of course sooner if the patient reports any recurrence of facial swelling, arm swelling, or other symptoms.
And given the complexity, the potential for recurrence, the need for coordinating interventions in oncology care, multidisciplinary care seems essential.
Absolutely essential, particularly for complex or recurrent SVCS. This necessitates close collaboration between the hospitalist, medical oncology, radiation oncology, interventional radiology, and sometimes thoracic surgery to ensure comprehensive, coordinated long-term management.
Okay. Finally, let's touch on the key areas of clinical uncertainty that still exist in the literature. These directly impact our decision-making at the bedside. These are the areas where the evidence is maybe lacking and practice remains more art than science.
There are definitely a few important ones.
What's the biggest one, in your view?
I think the largest and most immediate area of uncertainty for the hospitalist is the optimal regimen for anticoagulation and antiplatelet therapy after stenting.
Right. Given that up to 27% of stents fail within a year due to stenosis or thrombosis, you'd think there would be a clear guideline on how to prevent this.
You would think so. Yet, there's a profound evidence vacuum. Practice varies wildly across institutions, even within institutions sometimes.
So no clear answer on antiplatelets versus anticoagulation? Or both? Or for how long?
No definitive prospective data to guide whether we should use antiplatelets alone, anticoagulation alone, or a combination of both, and for how long. Especially when you try to differentiate between malignant and benign etiologies, the risk-benefit analysis is completely different.
How so?
Well, for a patient with advanced malignancy and maybe a 6-month prognosis, the focus might be purely on short-term patency and symptom relief, perhaps accepting a higher bleeding risk from dual therapy. But for a benign occlusion in a young person expected to live for decades, the long-term durability of the stent and minimizing long-term bleeding risk from anticoagulation become much more critical factors.
That makes sense. What other uncertainties exist?
Well, while the Yale system provides critical bedside guidance for urgency, there still isn't a globally standardized severity grading system used consistently for academic research. This complicates comparing data across large studies and developing universal consensus guidelines, especially when trying to study the effectiveness of different management protocols based on severity.
Right. Hard to compare apples to apples across studies.
Exactly. And naturally, flowing from the high reintervention rate, the optimal management strategy for recurrent SVCS isn't fully standardized either.
Meaning, if a stent fails, what's the best next step?
Yeah. Do we just re-angioplasty the old stent? Do we place a second stent inside the first one? Should we use covered stents to prevent tissue ingrowth? Do we escalate anticoagulation or add antiplatelets if they weren't already on them? These are significant clinical challenges that currently lack definitive, standardized answers based on high-level evidence.
Okay. So, to summarize our deep dive today, the management of SVCS really follows a critical stepped sequence. First, stabilize.
Right. Stabilize the patient with immediate supportive care head elevation, oxygen, and most critically, be ready for rapid endovascular stenting for any grade 3 symptoms, stridor, significant cerebral edema, or hemodynamic instability.
Second step, diagnose.
Diagnose the specific etiology. Adhere to that ACCP guideline. Obtain a tissue sample, ideally from a low-risk peripheral site like a lymph node or pleural fluid, if the patient is grade 1 or grade 2 and stable enough for the workup.
And third, treat the cause.
Treat the underlying cause based on that diagnosis. Systemic chemotherapy for highly chemosensitive tumors like small cell lung cancer and lymphoma. Radiation therapy and/or endovascular stenting for solid tumors like non-small cell lung cancer.
Yeah.
And primary angioplasty and stenting for most benign device-related thrombosis or stenosis.
Now, given that high rate of reintervention we discussed up to 27% due to stenosis or thrombosis after endovascular therapy and the real uncertainty across current guidelines, the hospitalist has to deeply consider the immediate clinical setting.
Yes, you have to weigh the patient's bleeding risk, the underlying cause, malignant versus benign, the prognosis, and the goals of care when deciding on an empirical anticoagulation or antiplatelet protocol post-stenting.
Which raises the essential provocative question for you, the clinician listening, navigating this knowledge gap. How should you practically navigate this current evidence vacuum regarding combination antiplatelet and anticoagulation therapy? Specifically, how do you balance the bleeding risk against the need for durable stent patency when managing malignant versus benign superior vena cava stenting, especially until definitive prospective data emerge?
That decision really requires merging the pathophysiology, the patient's prognosis, their individual risk tolerance, often without clear guidance from robust trials. It's a true testament to a current challenge in hospital medicine.
Where, in some ways, the life-saving mechanical fix the stent is now ahead of the long-term pharmacologic solution to keep it working.
Well put. That summarizes the challenge nicely.
Thank you for joining us for this in-depth look at SVCS. We encourage you to review the Yale grading system and the ACCP guidelines on tissue diagnosis as you approach your next patient presenting with swelling of the head and neck.